we're happy to have Dr. Paul Monach today, and he'll be talking to us today about vasculitis, giant cell arteritis, and polymyalgia rheumatica. Dr. Monach, thank you for joining us.
All right, thank you. It's good to be here. I do some consulting and I do participate in clinical trials. I want to summarize some of the key points. The first is the term vasculitis encompasses a lot of different diseases. The one feature they have in common is inflammatory destruction of blood vessel walls. Otherwise, a lot of diversity, as I'll get into. There's also diversity within each disease as well. The diagnosis is done kind of in the old-fashioned way of putting together generally a history, physical exam, objective findings that almost always include labs and either imaging or biopsy. Vasculitis is highly treatable, but we have to treat it in order to prevent disability or sometimes even organ destruction and death. We don't see that very much anymore because we can treat it, but that requires drugs starting with glucocorticoids. Advances in treatment are being made that are generally aimed at reducing the exposure to glucocorticoids with their well-known toxicities. So this is an old-fashioned way of classifying the vasculitides based on vessel size, but fortunately it has held up as more has been learned about the pathophysiology. There are good correlations involved, especially at the ends. And that's what I'm going to talk about most today is the small vessel vasculitides on the left and the large vessel vasculitides, particularly GCA on the right. So just trying to put all of them together again, I did mention they have this shared feature of inflammatory destruction of vessel walls. With the small vessel, what I mean by that is too small to have a smooth muscle layer. So arterioles, capillaries, and venules. This is neutrophilic inflammation that is necrotizing, and then it heals with revascularization. Medium vessel, which is predominantly the disease polyarteritis nodosa, is also neutrophilic at the beginning and causes necrosis in the vessel wall, but then proceeds fairly quickly to a mononuclear cell infiltrate that resolves a little more slowly over time. Large vessel disease is quite different, and it starts with a mononuclear, meaning lymphocyte and macrophage infiltrate right in the middle of the vessel wall and is non-necrotizing, and the endothelium is dysfunctional secondarily. The symptoms are generally relatable to a few things. One is tissue ischemia and sometimes infarction, and this varies, as you might imagine, with what the organ system is. So, for example, inflammation in the kidney doesn't cause any pain. There are sometimes symptoms that are attributable to the inflammation in the site, and the skin is a good example of that. And also, a lot of these diseases are associated with systemic inflammation and constitutional symptoms. There are many vasculitic syndromes, as you saw briefly on the last chart. They often have people's names associated with them, although those are gradually disappearing. But we also see vasculitis in association with other autoimmune diseases and sometimes with other exposures, rarely with malignancy. And there are a lot of people who don't fit those classification schemes. I would say the named diseases are more common than the unnamed ones, but we also see a lot of single organ vasculitis and people who, as I said, don't fit into the scheme of the sizes of vessels in particular. So how do you diagnose this? It depends on the type of vasculitis. So the small vessel diseases are at the top here, immune complexes and ANCA-associated disease. ANCA-associated disease, the ANCA is one of the most helpful lab tests we have in rheumatology. So sometimes you don't even need a biopsy. With immune complex vasculitis, the labs often don't tell you what's going on and you really need the biopsy. Polyarteritis nodosa encompasses vessels large enough to see on angiography and small enough that you can still find them by biopsy sometimes. Giant cell arteritis is a large vessel disease, but you can biopsy the temporal artery, as you probably know. But sometimes the diagnosis is made based on usually CT or MR angiography. Takayasu's is almost always an angiographically defined disease in the right clinical setting. And so it's the clinical setting that puts all of this together. And it is very difficult to make the diagnosis if other things in the history don't fit. So all of these diseases are considered rare, but that varies a lot, anywhere from 1 in 100 over the course of a lifetime to 1 in 100,000 as far as we know. There's a lot of variability. So Behçet's disease, for example, is actually relatively common. In Turkey, a little less common, in other places along the Silk Road and quite uncommon in other ethnicities, but we see it. IgA vasculitis, formerly known as panaxillary line purpura, quite common in children, rare, but we see it in adults. The ANCA diseases are all on the uncommon side of things, but 1 in 10,000 overall. Polyarteritis nodosa Takayasu's among the least, and single organ disease in the skin is quite common, in other organ systems quite rare. These are the ones I'm going to talk about today. Giant cell arteritis, I put a few different pluses because it varies with ethnicity, but as I'll get to, it is exclusively a disease of older people. So there is some evidence behind treatment. This has been one of the big advances in the past 20 years since I've been in practice. But there's a common element that even the most common of the diseases I just showed you have a lot of questions that haven't been assessed in high quality clinical trials. We do have evidence from multiple randomized trials in ANCA-associated vasculitis, meaning generally GPA, formerly known as Wegener's, or MPA. Quite a few randomized trials in giant cell arteritis and in Kawasaki disease, which I'm not going to talk about because it's exclusively a disease of children. There are a couple of other diseases where there's some really important trials, but not very many. So we still are sort of winging it with patients with EGPA or Churg-Strauss, and in patients with cryoglobulonemic vasculitis, unless you can cure it by curing hepatitis C. And then some of the less common ones, we are relying mostly on uncontrolled trials, or the few trials that might have been done might be negative, so they don't really help us, and a lot of case series. So there is a lot of experience, rightly or wrongly, in how we treat these diseases. The principles, though, are pretty much the same. And I'm sorry there's so many words on this slide, but some of the syndromes are mild and self-limited, and that's especially isolated cutaneous vasculitis. Glucocorticoids, unfortunately, we use them a lot. Generally, the more severe the disease, the higher the dose we start with. However, that doesn't necessarily predict responsiveness. So for example, IgA vasculitis, cryovasculitis sometimes simply don't respond to glucocorticoids well. We do use non-steroid drugs. In the most severe diseases, we have to. Prednisone alone will not do the job. In other cases, it's because prednisone is so toxic that the second drug is added. So where I say mildest cases, this really refers only to skin disease. So non-immune suppressive drugs like colchicine, dapsone, and hydroxychloroquine, all anecdotally, including my own anecdotes, are often quite helpful. But much more commonly, we use some of the usual suspects of rheumatology, the oral immune suppressive drugs. I think probably in order here: methotrexate, azathioprine, mycophenolate, less commonly leflunomide and cyclosporin. In severe disease, we traditionally have used cyclophosphamide, anything that is organ-threatening and could produce potentially either life-threatening or incredibly disabling syndromes such as neuropathy. So the biologics is what have been investigated more recently, and generally by comparison to the oral immune suppressive drugs. And here's where they don't seem to translate across diseases. They're still very blunt instruments. So rituximab depletes all peripheral B cells that bear the marker CD20, but it is useful for diseases that are mediated by antibodies. Tocilizumab blocks the IL-6 receptor and happens to be useful for giant cell arteritis and probably for Takayasu's. Mepolizumab very specifically blocks interleukin-5, which is an obligatory growth factor for eosinophils. So as I said, not specific in what they do, but in terms of the different forms of vasculitis and their pathophysiology, actually quite specific. So I'm going to start with the individual small vessel vasculitides, which starts with a long list, but it's actually not nearly that complicated. And it's definitely not as complicated as this. I put this together to show that when you see palpable purpura, you don't necessarily know what is going on. And even when you have biopsy proof of leukocytoclastic vasculitis in the skin, you don't know what's going on either. But it's narrowed down to pretty much these two things. So small vessel vasculitis is usually mediated by ANCA or associated with ANCA or associated with immune complex deposition. Immune complexes are involve antibodies and the antigens they're bound to in a way that there are multiple antibodies and multiple antigens in a big clump rather than just a one-to-one correspondence, and that's why they deposit in the walls of blood vessels. So first I'm going to talk about the ANCA-associated diseases. This isn't quite right. It's still autoimmune anytime you have anti-nuclear cytoplasmic antibodies, but in a very small percentage of cases, it's drug exposure from drugs such as propofol or Uracil. But one way or another, you develop autoimmunity. Most of the time it's idiopathic. You get ANCA, and these, I can't get into all the details, but probably cause vasculitis, at least in the kidney. Here's what it looks like, but we don't rely on the cytoplasmic staining anymore. This is cytoplasmic staining, or C-ANCA. This is perinuclear staining, or P-ANCA. This is actually a laboratory artifact. They both are cytoplasmic antigens. This is what matters. The known autoantigen is proteinase 3 or PR3, and the known autoantigen associated with this pattern is myeloperoxidase, or MPO. So that's what really helps you make a diagnosis in the right clinical setting. I'm going to name the three diseases. One is microscopic polyangiitis, or MPA. This is a small vessel necrotizing vasculitis, and it is highly associated with MPO-ANCA, to the point that it's almost a circular argument that it's hard to make this diagnosis in some circles if you don't have MPO-ANCA. GPA involves all of the same features of MPA, not in the same proportions as I'll show, but you have to, in order to make this diagnosis, you have to have necrotizing granulomatous inflammation somewhere else. And that's usually the upper airway, the nose and sinuses, eye, ear, trachea, often in the lungs, and a little less commonly in the skin. The great majority of these patients have PR3 ANCA. Some also have MPO ANCA, and some, especially if they have more limited disease in the upper airway, won't be ANCA positive at all, which is a diagnostic challenge. And then EGPA, or Churg-Strauss, in order to make that diagnosis or feel confident about it, the patient has to have vasculitis somewhere, although it often does not dominate the clinical picture. Almost all these patients have elevated levels of eosinophils in the blood, generally above 1,500. They almost all have asthma, and they really have asthma without always having eosinophilic pneumonia. But often if you look, there's eosinophilic inflammation somewhere. And only a minority of patients have ANCA disease. So this is a complicated disease to discuss, but I just mentioned that in passing. So here are the organ systems involved in GPA to give you some idea of the diversity. The thing is, in almost all these cases, these manifestations could occur either by small vessel vasculitis or by necrotizing granulomatous inflammation. That's especially true in the lung, where you can get pulmonary alveolar hemorrhage, or you can get large cavitary nodules, or you can get a variety of infiltrates in between. Up in the upper airway, the nose and sinuses, the granulomatous damaging inflammation predominates. In the kidney, it's almost entirely glomerulonephritis, which people argue about whether you should call that vasculitis or not. The eye, you can get either type. Nerve is pretty much vasculitis. And then fortunately, you can see that these three organ systems are quite a bit less commonly involved. Here are some examples. I just want to focus on the middle and the right side. I don't know if you look in a lot of noses. I do. This is what it looks like when the mucosa is normal or healed in a patient. This is what it looks like when it has severe inflammation. It often could be a lot more patchy than that. There might be there might be a third as much of the extent, but that degree of inflammation either heaped up or eroded. And when it erodes, it gets a kind of a chronic eschar on it, and then it will periodically wash out, and patients will describe very large crusts that wash out, but the underlying tissue doesn't always heal. This is a normal larynx. Obviously, I don't see those, but my ENT colleagues do, and I rely on them to do fiber optic exams to be able to tell. Much like the nose, this is what it looks like when it's inflamed and narrowed, and it's usually circumferential, and it can get actually quite dangerously narrow and can cause actually a permanent stenosis as well, which has to be manually opened. We hope not to get to this point with nasal damage. Septal perforation is quite common, and sometimes there's progressive enough destruction that a saddle nose deformity occurs. We still do see that. This is one of the forms of eye disease in GPA. This is a vasculitic one called scleritis. It's a painful and often vision-threatening but treatable eye disease. So this is the radiographic appearance of alveolar hemorrhage. This is not pathognomonic, but it's awfully suggestive when it's extensive, bilateral, heavily consolidated. If this patient were coughing up blood, that's enough to say the patient has alveolar hemorrhage, but you don't necessarily know a diagnosis. Otherwise, we rely on bronchoscopy and rarely on biopsy to make that diagnosis. This is, of course, a biopsy, kidney biopsy showing glomerulonephritis, which again has a differential diagnosis. But in ANCA-associated vasculitis, it is one of the crescentic forms, meaning you start, there's enough inflammation that you get infiltration into Bowman space. You rarely actually see, or seldom, fibrinoid necrosis. You don't have to have vasculitis, you just have to have glomerulonephritis. And either of these pictures could be GPA or MPA, and it depends on whether the patient has granulomatous inflammation somewhere else. But about 80% of the time, the combination of glomerulonephritis and diffuse alveolar hemorrhage, about 80% of the time it's going to be GPA or MPA. So here are the organ systems that, if you have somewhat in your head what I showed for GPA, you don't get ENT or eye disease. The lung disease is pretty much limited to alveolar hemorrhage, so different from GPA. The kidney is much more frequently involved. These again are infrequent. So that's the big difference. Kidney in the absence of ENT and eye disease. This is very briefly how we treat these diseases. You have to be very aggressive up front. This is one of the few conditions in rheumatology that where prednisone alone you don't rely on when the disease is severe. So traditionally we started with cyclophosphamide. We can thank actually Tony Fauci and colleagues for introducing this life-saving therapy in addition to prednisone. It was a little later that you can transition to a safer drug for maintenance therapy. One of the big advances in the field in the past 20 years was the substitution of rituximab, B-cell depleting antibody, for cyclophosphamide. How you then use it afterward depends who you ask. You can either stop it and see what happens, or you can continue it for 2 years or indefinitely, or you can switch it to azathioprine. And so I'm going to skip over the many questions that we argue about in the field. But we actually have randomized trials addressing a lot of these things. And basically, the more aggressive the therapy down here, the better it works, and we think the more toxicity risk. For milder disease, you can again take all these approaches with rituximab, but methotrexate becomes an option instead, and other oral immune suppressive drugs too, but not necessarily cyclophosphamide. So eGPA is quite a bit different. The organ systems, as you can see, neuropathy is quite common, and I list ENT and lung disease, again, common. But what is different in this case is that most of the time this is not vasculitis. And in fact, some of the more common in ENT disease, it's nasal polyps or eosinophilic sinusitis. Here it's asthma and eosinophilic pneumonia. GI and heart disease, this is again eosinophilic disease, even though in the heart it can be quite dangerous. So that isn't necessarily vasculitis. This is a disease that includes both aspects. How we treat eGPA, briefly, if it's bad, we use cyclophosphamide. If it's not so bad, we use other drugs. And here's what's different is this is a highly steroid responsive disease, but it's also there's a high degree of steroid dependence. So almost every patient ends up on one of these other drugs. These are oral immune suppressive drugs, azathioprine, methotrexate. Mepolizumab, again, is the IL-5 antibody, and it's not perfect in this disease, but it's pretty effective as a steroid-sparing agent, and that ends up being our goal with this disease. So I'm going to talk very briefly about immune complex disease, basically just to say that it has quite a differential diagnosis on its own. And here are the rough percentages: drug exposure, infection. Often we don't know which infection, there's just a hint of it. And a lot of times you can look pretty hard and not figure it out. Most patients do not have an underlying autoimmune disease. There are two that are named. I just throw this in for completeness: cryoglobulinemia and IgA vasculitis. I'm going to almost skip over polyarteritis nodosa in the interest of time. This is happens to be a pediatric case, rare, exciting thing for us in the field that a mutation in this disease, in this gene called ADA2, was found to be associated with pediatric development of this disease. It can affect anything from the smallest thing that you can call an artery, causing livedo in the upper right panel, to something that is just a branch right off the SMA. So a wide range in vessel sizes. This sometimes is a disease limited to the skin or to the skin, musculoskeletal system, and nerve, less commonly involving internal organs. And when that happens, it's more likely monophasic. So now we get to GCA, giant cell arteritis. I wish the temporal artery looked like this in most patients. It does not. I wish the temporal artery biopsy looked like this with transmural inflammation. It often does, but a lot of times it doesn't, and you can't even tell it's abnormal. I want to spend a little time on the symptoms and signs. Most patients have a headache, but many of them do not. That headache should be unrelenting and not relieved by non-steroidals, for example. A lot of patients have constitutional symptoms, polymyalgia rheumatica, which I'll get to. Jaw claudication is described as one of the most specific points of history, but you have to ask the questions right. Patients often have scalp tenderness, but sometimes they don't. As I said, sometimes you'll see an obviously abnormal temporal artery. Shoulder exam is nonspecific, but patients often can't lift their arms over their head, and we rely on our ophthalmology colleagues. Unfortunately, this disease still presents with 10 or 15% vision loss before we have a clue that the diagnosis is in the works. Branches of the carotid artery are involved. Why this really causes pain is not clear because the tissue is not ischemic in the sense it does not become infarcted, but it's quite painful and the scalp is often tender as well. The muscles of mastication get supplied by branches as well. And so do, unfortunately, branches of the ophthalmic artery, the posterior celiac artery going to the retina. And so my arrows are off here, but basically you can get large vessel vasculitis. Symptomatically, in probably 10% of patients, this patient is missing her subclavian arteries, but it happens so gradually that collaterals expand and she merely has bothersome claudication rather than actually being at risk of losing a finger. Polymyalgia rheumatica isn't particularly well understood. It's usually a combination of arthritis, bursitis, and tenosynovitis, and that's why it's such a vague syndrome. The patients, we check for antibodies related to rheumatoid arthritis because that's the major mimic. The lab tests just show inflammation, ESR and CRP, and that's generally it. The clinical syndrome usually features bilateral shoulder pain. And then in addition to that, a lot of patients will have hip girdle or posterior neck pain, but they often can just feel lousy all over. It's different from fibromyalgia, but they'll often have a lot more than just that. Some will have overt peripheral arthritis, and it's hard to tell from difference between that and rheumatoid arthritis, and constitutional symptoms are really common. Here's just briefly why people have this is an example. We didn't know this until we had advanced imaging studies like MRI, that's bursitis. This is glenohumeral joint arthritis, and that's bicipital tenosynovitis. This I thought was really neat, a study that showed that bursitis between the spinous processes that can occur in this disease and probably explains neck pain. Epidemiology, this really is a disease of older people and generally much older than 50. The cases of biopsy-proven giant cell arteritis, temporal arteritis are really, really rare. And PMR follows a similar epidemiology. Majority female, but certainly seen in a lot of men. This is not a purely European disease, but it is thought to be mostly. So just remember in the US, not much study of this, but African Americans, probably a quarter as common once you get to the age of 80. And it's thought to be quite rare in East Asia and South Asia. So how do you make the diagnosis? Well, you send both the CRP and the SED rate. And the reason is that either alone is not sensitive enough, but together, if they're both normal, the patient's really unlikely to have this disease. Temporal artery biopsy, if you get more tissue, you are more likely to have a positive biopsy, but people argue about how to put that into an algorithm. And even so, no matter how much you take, there are clearly patients who have GCA in whom the biopsy will be negative, and that makes it hard. So the ultrasound, this is a big area of interest, but it's done at expert centers, ultrasound or MRI or PET scanning, all in the 80% range. So in the end, we either treat or don't treat these patients, as in a lot of medicine. And unfortunately, in rheumatology with giant cell arteritis, we're often in this situation. These are the two things that are widely available, the markers of inflammation and biopsy. We always start with some sense of all that list of features that I showed you. Obviously, this is very vague, and here's how they kind of go together. And so obviously, this is complicated, but if somebody has a high suspicion and they have a high saturated CRP, I'm probably going to treat them anyway, but I'd usually like to be sure. And if I have kind of a low suspicion, a new onset headache in an elderly person, and they have normal inflammatory markers, we're done. But unfortunately, sometimes I'm not sure, and I treat with prednisone and see that's a slippery slope, as you can imagine. And a lot of times we're really in this position. So that's why we need imaging. I just say in passing that in between high inflammatory markers, biopsy negative, what do we do? Prednisone is used for all patients still, but an exciting development in the field was tocilizumab, an antibody against the IL-6 receptor. Some people use it up front. Some people only use it once the patient first has symptoms of relapse, and methotrexate is sometimes used as well, though the evidence isn't as strong. PMR, same thing. The only non-steroid drug that has been shown to work is methotrexate, and it's not used that frequently. We start with much lower doses. You probably want to know this, but I want to just emphasize. We start with anywhere between 10 and 25. I follow these patients quickly. This is my own little calculation of how often I want to see them. These are old people, and if they weren't frail to begin with, they become frail once you put them on high doses of steroids. It's often gone between 1 and 3 years, but not always. I check them in follow-up, but I try not to treat on the basis of the markers alone. It depends how devastating it would be for a patient to have a relapse. And screening for side effects is something we do when we're being good doctors, but we often rely on primary care to help with that as well. I'll just mention that we should do some sort of screening for large vessel involvement because there's a risk of a thoracic aortic aneurysm in 6%. So I apologize for this being a long question here, but I'll just summarize it as saying patient with 2 months of musculoskeletal and constitutional symptoms, 2 weeks of a numb right foot that is supported by findings on exam, 3 days of being progressively short of breath, low O2 saturation, dense bilateral pulmonary infiltrates, and then has, in addition to markers of inflammation, has elevated creatinine and hematuria. So I don't know where to go from here. Okay, I think I'll go on because I'm short of time here. So I can't go through all the answers here basically, but this is a patient with pulmonary renal syndrome. It would have been easier if I just said she's coughing up blood as well. The reason you have to call it MPA is there's no mention of her having GPA, symptoms, granulomatous disease. Lupus could do this, but actually pulmonary hemorrhage is quite uncommon. Patients also typically have a lot more proteinuria, and then PAN doesn't affect the lung. Doesn't actually cause glomerulonephritis either, but they can cause hematuria. So this is a shorter one. In a patient with giant cell arteritis, what do you need to do? The patient might be done with the disease, they're done with treatment, they haven't been on prednisone for years. What do you need to keep looking at? And obviously this is going to depend on the patient and what was abnormal before. Sorry, I meant just in terms of GCA itself. Okay. I think that's good enough. And yes, I agree. The thoracic aortic aneurysm, obviously, if the patient has diabetes, has osteoporosis, you'll keep on these other things. I personally don't keep following the ESR and CRP. Most patients, once they're done with treatment, do not have a relapse of this disease, although it can happen. And that is it.